Jhpiego believes that when a mother survives, her children thrive and communities prosper. And no matter where she lives, every mother and her newborn have the right to quality care during childbirth.
मेरा नाम संतोष है। मेरे 4 बच्चे, चक्कर आया, घबराहट हो गई थी, कोई हो जाएगा मेरे को।
संतोष जब आई तो वो कंप्लेन लेकर आई कि उसको धुंधला दिखाई दे रहा है, उसको दिखाई नहीं दे रहा है, वर्टिगो हो रहा है, पैर में स्वेलिंग थी, उसकी बीपी भी ज़्यादा थी।
मेरा नाम दुर्गा गायरी है। ये मेरा फर्स्ट बच्चा है। हाँ, फर्स्ट डिलीवरी थी तो डर लग रहा था और ब्लीडिंग ज़्यादा हो रही थी तो पेट में मालिश की।
Every day, about 800 women die around the world from preventable causes related to pregnancy and childbirth. High blood pressure and severe bleeding after childbirth are among the leading causes of these deaths. In 2015, Jhpiego partnered with the Rajasthan government to save lives by strengthening the quality of care around childbirth. Skills, practice, mentorship, ensuring essential resources, an enabling environment, and better data for decision making have been the hallmarks of this program called Dakshata. And the impact has been remarkable. Close to 2 million women, including Santosh and Durga, gave birth with a skilled provider by their side and received the quality childbirth experience they deserved. Today, Rajasthan has achieved the highest decline in maternal mortality in the entire country.
दक्षता मीन्स एक हाईएस्ट स्किल लेबर रूम की टीम के साथ में रहते हुए और हमारे जो प्रोग्राम ऑफिसर्स हैं वो उनको की प्रैक्टिस एरिया के ऊपर हैंड्स ऑन ट्रेनिंग देने के साथ ही पूरा प्रोसीजर सिखाना और उसको रिपीट करना, रेगुलरली उसको अप्लाई करना पूरे सिस्टम में, और उसके पार्ट के ऊपर दक्षता प्रोग्राम आया। Jhpiego ने कम्प्लीटली इसकी ट्रेनिंग, इसकी मेंटरशिप वगैरह का पूरा जिम्मा लिया और हर बार नई चीज़ सीखना, अप्लाई करना, जो पढ़ी थी बुक्स के अंदर वो हाथों से करने को पहली बार मिल रहा था और रियल टाइम वो सही प्रोसीजर्स थे जो हमने बुक्स में पढ़े वो कहीं ना कहीं हमारी प्रैक्टिस में आने चाहिए थे, वो आने लगे। हमारा लॉजिस्टिक बढ़ रहा है, हमारा इंफ्रास्ट्रक्चर तैयार हो रहा है, डिग्निटी एंड वर्क एरिया हमारा बहुत अच्छे हो रहे हैं। क्लाइंट सेटिस्फेक्शन वाली बात है और हमारे जो लेबर रूम में स्टाफ काम कर रहा है उनके बिहेवियर और उनके वर्क स्टाइल में रात दिन का परिवर्तन आया है। वो अपने आप को कॉन्फिडेंट फील करते हैं।
तो दक्षता ट्रेनिंग से पहले हम हाई रिस्क डिलीवरी ऐसे मोस्ट केस को वो रेफ़र करना पड़ता था। उनका रेफर कम हुआ, स्टिल बर्थ कम हुए, कहीं उसका डॉक्यूमेंटेशन कहीं नहीं था। अब उसके बाद हम इसके हर आधे घंटे में इसके वाइटल साइंस चेक किए तो उसको डॉक्यूमेंट करते हैं, बच्चे में किए तो उसको डॉक्यूमेंट करते हैं। जब जब बच्चे को चेक किया तो उसका डॉक्यूमेंटेशन रखा है, उसका पार्टोग्राफ मेंटेन किया है। डॉक्यूमेंटेशन में हम यदि किसी महिला को रेफ़र भी करते हैं तो उसके विद पार्टोग्राफ लेबर स्लिप के साथ और वहाँ के डॉक्टर इंचार्ज या लेबर रूम स्टाफ को इन्फॉर्म करके और हमने क्या मेडिसिन दी, क्या किया, उसके विद उसको रेफर करते हैं।
Dakshata developed digital tools to standardize data recording, reporting, and monitoring, like a digital platform for recording labor room case sheets and customized Android-based application for real-time labor room monitoring.
ऑनलाइन का बहुत हमें उससे बहुत फ़ायदा हुआ है, यानी कि जैसे कार्ड भरते हमें इतना टाइम लगता था, उसमें हर चीज़ बार बार रिपीट करनी पड़ती थी। ऑनलाइन से ये फटाफट ऑनलाइन किया, उसके बाद में हम दूसरे पेशेंट को भी देख सकते हैं।
सारी प्रैक्टिसेस जो दक्षता में होती है वो पंच होती है और इसके बाद स्टेट के डैशबोर्ड पे, डिस्ट्रिक्ट के डैशबोर्ड के ऊपर
हम यहाँ पे कैसे बायोमेडिकल वेस्ट का मतलब निस्तारण करेंगे और आपके लेबर रूम की क्वालिटी ऑफ सर्विस कैसे मेंटेन करनी है, वो सारी चीज़ें इन लोगों ने हमको बताई। तो कितनी चीज़ों की सावधानी बरतनी चाहिए, लेबर रूम का एनवायरनमेंट क्या होना चाहिए, बर्थ कंपेनियन होना चाहिए, ये सारी चीज़ें हमने सीखी Jhpiego और दक्षता से। हमारा स्टाफ वो नॉर्मल डिलीवरी करवा रहा है, आज PPH को भी देख लेता है, आज हमारा प्रेगनेंसी इंड्यूस हाइपरटेंशन को भी देख लेता है, आज हमारे यहाँ लो बर्थ वेट बेबी को भी देख लेता है, KMC भी करवा देता है, ब्रेस्ट फीडिंग के बारे में भी एडवाइज कर देता है और पास में खड़ा होकर विदिन 1 आवर के अंदर ब्रेस्ट फीडिंग के लिए भी मोटिवेट कर देता है।
What Jhpiego started in Rajasthan is now the Government of India's flagship quality improvement initiative across 25 states. The mission remains the same: to save lives, improve health, and transform futures of mothers, children, families, and communities.
कि मेरी डिलीवरी यहाँ अच्छी हुई है, सब अस्पतालों में ऐसी होनी चाहिए और साफ सफाई रहनी चाहिए।
बहुत बड़े सपने देखे इसके लिए।
So, hello and good evening on this January evening to NQOCN's Community of Practice session. Today we are delighted to host a team from Jhpiego, and they would be talking about strategic initiatives to improve quality of intra and immediate postpartum care in Indian public sector. So, in order to begin, yeah. So I'll quickly go through the agenda for today's session. So we'll have a formal welcome to the session, to this community of practice session by Professor Vikram Datta, who is President NQOCN and Director Professor Department of Neonatology at Lady Hardinge Medical College. After that, we'll have improving quality of care, quality of MNH care, the journey so far, taken by Dr. Bulbul Sood, who is a Senior Strategic Advisor at Jhpiego. And then we'll have a more holistic discussion on Dakshata, its journey, how it came about, what are the various training packages, how the data was used to develop quality to ensure quality improvement across the facilities. And we'll also have the financing perspective from learnings from Safe Childbirth Checklist, from pilot to policy, a more holistic overview of the whole program. And we'll end with a Q&A session and concluding remarks and vote of thanks. So I'll introduce Professor Vikram Datta, the first speaker for the day. Professor Datta is Director Professor, Department of Neonatology. He's also President of Nationwide Quality of Care Network and the Vice President at National Neonatology Forum of India. He's the guest editor, BMJ, Open Quality South Asia Edition, and member editorial board for International Journal for Quality in Healthcare Communications. It's a ISQA journal. He's an expert at International Society for Quality in Healthcare, that's ISQA, and a lead, NMG and Technical Resource Group lead for Sustainable Model of Lakshya program nominated by Ministry of Health and Family Welfare, and a member of Quality, Equity and Dignity Working Group of Ministry. So over to you, Professor Datta.
Thank you so much, Rahul. Good evening to all friends, especially to Dr. Bulbul Sood and her team from Jhpiego. Very happy New Year, ma'am, and a great start to the new year 2022. And I'm sure that this session is going to be an enlightening session with the entire team and the glitterati of Jhpiego around. I can see Dr. Sunita Dhameja, madam. Last we had met at the airport. And Dr. C.S. Joshi, Advisor, Clinical Services and Training, Jhpiego. And Dr. Hemang Shah, Director, SIF, and Dr. Somesh Kumar, Country Director, Jhpiego. And besides this, we are supposed to be having Dr. Rajesh Mehta, who just spoke to me a few hours back. He's having a concurrent meeting with Geneva headquarters, which is supposed to get over at 7:30. Unfortunately, it started at 6:30. And he said that as soon as it finishes, and if we are still around till 7:30, he will be joining and making the concluding remarks. He had a lot of observations, and we would be excited to look after, to hear all the details which he has to offer to this August gathering. I think maternal and neonatal healthcare is something which interests both the organizations, and it has been, NQOCN is a young organization. We hope to learn from today's session from ma'am's team and also from the experiences of SIF India. And we hope to see how we can collaborate and work together in the years to come, because the more partners work together, the better it is, because the unmet need of maternal and neonatal healthcare quality, and especially the last mile delivery, is something which is very, very important. So friends, I'm not going to be keeping you away from the glitterati of the speaking team. And I'm going to invite with great pleasure Dr. Bulbul Sood, Senior Strategic Advisor, Jhpiego. Ma'am, the floor is all yours, and we look forward to an exciting and an enlightening evening ahead. Thank you so much.
Thank you very much, Professor Datta. All the members of the NQOCN Society of India and members of the South Asia Committee of Practice. I see a lot of people whom we have worked together. Dr. Dinesh Baswal is there, Dr. Ramchair is there, and so many others, Dr. Rajesh, with whom we have been working since the beginning. It's really my proud privilege to welcome you all on behalf of Jhpiego to today's meeting. I'm delighted that, this is in the beginning of the year that we have been, given this opportunity to share our work, and, really look forward to collaborating with NQOCN. As Professor Datta has said, there's so much to be done. I know it. We have done a lot, but there is still a lot to be done, and our aim should be that at the end of the day, how we can ensure that we are able to provide quality care to millions of women and children newborn in this part of the world and prevent needless deaths. I would, can I have my presentation, please? Anusha, can you just share the presentation? So,
yes, ma'am.
Yeah, thanks. And a very, very happy new year to everyone. I know we are in the second year of the pandemic. Hopefully soon we should be able to say it was a past, but let's see how things are moving. So I'm just going to take you through the Dakshata strategic initiative, which we started in 2012. And this was done in a partnership with the national government and the state government of Rajasthan, and with support from Children Investment Fund Foundation. Next. Next. So the objective of today's meeting is, of course, to share the learnings with all the experts, and also to facilitate its adaptation based on the needs of the South Asia regional COP, and also look at how we can collaborate with the NQOCN India going forward. Next. So when we started this initiative, and everybody in this webinar is aware that the global evidence was showing that once you increase the institutional delivery rate, the maternal mortality decreases. But in India, although by 2010, we were seeing that because of the JSY, there was increased institutional delivery, but we were not seeing the corresponding decrease in maternal mortality. And that's why this whole initiative that we have to improve the quality of care during the time of childbirth was very critical. Next. And again, everybody in this room knows that, the maximum return of investment is when you, take care of mom and baby during the childbirth, and also take care of the sick and small babies, and that's where you get the return of investment. Next. We also knew that, we didn't have to do big things. Simple intervention could prevent large number of deaths, and things like Amstel could reduce PPH by 66%. Use of a very cheap drug, magnesium sulfate, could reduce progression to eclampsia by 58% and reduce death by 45%. Simple use of partograph again could reduce early neonatal deaths by 40%, and use of antibiotics for preterm premature rupture reduce the incidence of infection by 32%. Next. However, it was very important that all these high impact practices had to be performed in each case. It had to be performed as per standards. It had to be performed in a timely manner, and all practices need to be performed. And this, we all knew, that has had a big influence by the skills of the provider, the motivation of the provider, ability to translate skills into action, and a constant supportive supervision which was needed in the system. Next. When we talk about need of the quality of the normal labor, and we know all these practices are there, which are done at the time of admission or delivery, or within 1 to 2 hours or later on. But what we were seeing was that these were happening haphazardly. And next, it was important to have all these important practices being performed in the timely manner, but and that, as I said, ensure that it was done with all the patients at the time of admission, delivery within 1 to 2 hours, or at the time of discharge. And that's where next came the Safe Childbirth Checklist. I think everyone in this webinar is aware about the Safe Childbirth Checklist. This is a WHO Safe Childbirth Checklist, which organizes all the essential evidence-based birth practices. And these are 19 practices which are done in this 4 pulse point. And we took advantage of this, that if we are able to implement the Safe Childbirth Checklist in the labor room, we would be able to, improve the quality of care. Next. So we, as I said, in 2012, started the Safe Childbirth Checklist program in Rajasthan with support from the Children Investment Fund Foundation. We did an operation research in which in 7 districts, we selected 101 intervention facilities, and we had 99 control facilities in the control districts. Now we knew that the Safe Childbirth Checklist alone is not going to make the difference. So we ensured that in the intervention districts, besides having the Safe Childbirth Checklist as part of the case sheet, we also had a 3 days orientation of the staff, which was very competency-based, skill-based training, and supplemented by on-site supportive supervision and mentoring, and ensure that there were essential drug supply and equipment were provided. In the control side, we ensured that all the essential drug supply and resources were available. We followed this for 1 year, and we looked at changes in the in-facility perinatal mortality. Next. The key results of this independent evaluation of the Safe Childbirth Checklist program by PHFI showed that on an average, a client in the intervention facility received about 12 practices more than the control site compared to the baseline. More than 80% facilities that use the Safe Childbirth Checklist adhere to all the essential standards of care during childbirth. We also found that it was feasible, it was acceptable and useful, especially to the nursing colleagues who found this tool very useful, and they knew exactly what they had to do, when they had to do, and easy to record also. And it led to a reduction in the facility-based stillbirths and very early newborn deaths by 11.1%. And we found this also to be a very cost-effective tool. And for each life saved, it was $63. Next. We've shared this result with besides the state government, also at the national level. And this led to the launch of the Dakshata program in April 2015. And I'm happy to say today it is, being taken up by several states, and it's become a pan-India program. So I'll stop here and I'll hand it over to my colleagues to take you through the journey of the Dakshata program. Thank you very much.
Thank you, ma'am. I am sorry, I somehow my video is not coming. It says the host has disabled your video. So Anusha, if you can keep moving the slides, and if you can put on my video.
Komal, can you just make sir the co-host?
Yes, sir.
Oh, acha. Dr. Is that Dr. Somesh?
Yeah, that's Dr. Somesh.
So you have joined from, so I was searching for your name to make you, but it says Dr. Anusha. So we'll just make you the co-host, and you can share the video also.
Okay. So, but we can continue till then.
Sure.
So, Anusha, next slide. So, as you saw, our journey on the Safe Childbirth Checklist started in Rajasthan, right? So, the next leg of this journey was to codify the lessons from our Safe Childbirth Checklist project in Rajasthan and package it as a scalable project that can be then taken to scale in the entire country and in the entire state of Rajasthan first. So that is when the SCC, the Safe Childbirth Checklist project, was framed as the project as the national program called Dakshata, and there were 4 objectives to that program. One was first to strengthen the competency of labor room providers to ensure that after the competencies have been strengthened, they are able to practice. So that means ensure the transfer of learning post training. Third, make sure that availability of commodities is there at all labor rooms. And 4, ensure accountability through proper recording, reporting, and utilization of data. So this was the Dakshata program by the Government of India, which was launched in 2015. Next slide, please. So as you can see, this is the staggered and phased plan, scale-up plan for the Dakshata program. After we got the evaluation findings in 2015, initial evaluation findings of 11% reduction in very early neonatal mortality. So the staggered implementation included first going to 20 districts, 200 plus high delivery load facilities. And then after those 20 districts were covered, again within the smaller, within sub phases from June 2015 to August 2019, and then implementation where there was some overlap, May 2017 to 2019, another 55 facilities were added. So that's where the 20 districts were saturated, the high delivery load points, but from 2015 to 2019, and then the whole scale up of this program happened across the state of Rajasthan in all high delivery load facilities in 313 facilities. This was again led by Government of Rajasthan, with support from the Children Investment Fund Foundation and Jhpiego as the implementing partner. Next, please. What are the key components? So the key components, as I try to frame it very simplistically, are essentially 3 here, and we can break them into 4. So it's competencies, which include first initial training for providers, followed by on-site mentoring visits to ensure transfer of learning. So competency. Second, commodity. We identified 26 commodities that should be available at all labor rooms. So those availability of these commodities. And third is accountability. That is, the provider should have accountability. Once they are competent and they have everything that is required, they should be accountable to adhere to these practices. So how do you ensure accountability? Through proper measurement, monitoring, and management at all levels. So it's very, it is, to summarize, the 3 components were competency, commodity, and accountability through measurement. Next slide, please. So I'll start to share some learning, some data on the effectiveness, and come to the learnings, what are the key learnings that we had, and then we'll go deep through Joshi ji's and Dr. Sunita's presentation. So you can see here, we had 19 clinical standards against which we observed the adherence to keep practices and highest impact practices. And you can see at baseline it was 11% and it went to 63%. And there is the delta. You can see 63%. Why did it not go to 90% even after a lot of interventions? We have learnings for that. There were some indicators, some practices that you will improve through initial competency and availability of commodities. But then there are some related to more behavior change, like, for example, hand washing or the skin to skin contact and those kind of behaviors which are sometimes rooted in culture. So it takes time to change those practices over just by a competency and commodity strengthening program. So these are learnings that we then use to try newer strategies to take the standards from 63% to closer to 90% as it is happening now. We had 7 labor room standards on the infrastructure availability, and you can see it moved from 29% to 70+%. And these 26 commodities that I was talking about, before we started, it was 73%. It went to almost 100% at 96%. The next slide, please, Anusha. You can see the various, the journey of the project. It started in 2015. It's at national level. It gets launched at the state level in 2015, end 2015. And then once that happens, we started planning with the district levels through workshops, and then having these 3-day trainings for competency strengthening of the providers, facilitating the availability of key commodities at the labor rooms, and then very periodic reviews where you would get providers, nurses and doctors presenting their learnings directly to each other, not to anybody external or anything. So facilitating those review meetings. Next one. And this is an interesting slide, and it needs some explanation here. So just see here, you can see and there is a probably mislabeling here. So the dark line, you can see the dark graph, the lower graph. You see, these were the initial 20 districts where Dakshata was implemented. I told you about the staggered implementation. And you can see the scale up, the implementation picked up in 2016 to 2017. And you see the PCTS data showed sudden decline in the stillbirth cases or stillbirth rate in these 20 districts, what we call the initial Dakshata facilities, from 18.9 to 16.4. So the curve you can see is a bit steeper than the secular trend that you are seeing on the top side of the other graph, the light yellow graph, light blue graph, that is. Now, once the Dakshata implementation was Dakshata was scaled up across Rajasthan in the rest of the facilities, as you saw in my staggered implementation date timelines, you saw that the scale up happened from 2017 to 2019 across the state. You can see a bigger drop from 19.3 to 18 in those facilities in the stillbirth rate. And while these graphs, we see a lot of them every day, this tells a very powerful story here. Within each 1 point stillbirth rate fall are thousands of babies who would have died and who have survived just because of preventable high impact practice adherence. And so I think this is a very powerful slide for me, more powerful than any impact data that we see. And the timelines definitely tell a story here that we can attribute, we can say that Dakshata contributed to this sudden drop or rapid drop during specific phases of time when Dakshata was implemented. Next slide, please. This was also evaluated externally, funded by our donors through Public Health Foundation of India, and as per findings from our data that we showed earlier, you could see an improvement in availability of commodities from 60% to 84%, and in Rajasthan. And we also did this project in In Andhra Pradesh, on demand from the political leaders there, the policy makers, and it went from 74% to 87% in Andhra Pradesh, with very little, just one or two key people at people at the state level to facilitate the whole processes. We also saw, that the key practices which you saw 63% approximately in the initial Dakshata implementation phase, those increased to around 75% when the evaluation was done through external evaluation agency, and in 75% adherence to in Rajasthan of all key clinical practices, and 70% in Andhra Pradesh. And in SRS, and this is where we will say to read this with a lot of caution. We don't attribute any project to lead to to things like maternal mortality reduction in the whole state. Many things would have contributed, and state level inputs as well. But what we saw definitely was Rajasthan in this period, exactly 2015 to 2020, saw the maximum mortality reduction in terms of percentage points. So the MMR reduced by 22% points in Rajasthan, highest decline in any state of India. So again, read this with a caution, because this is not completely attributable to one project or one set of intervention, but we do feel that we would have this project, this initiative, Dakshata would have contributed in a very, very, very significant manner to the MMR reduction in Rajasthan. Next slide, please. So what did we do? So as we were, this was the story of Rajasthan, right? So 2015 to 2020. As we were scaling this up, we went, since the scale up happened at national level also. So through support from SIF and other donors, we started implementing, scaling up Dakshata across the country. And you can see the scale up map that is depicted here. And it's like really huge, 2,000 facilities across the country. More than 16,000 providers have been trained. More than 1,700 master trainers developed. This is what you leave behind as sustainability. 8,000 mentoring visits have happened through non-Jhpiego, essentially most of the visits through non-Jhpiego, non-project staff by state mentors post-training at these labor rooms. And around 9 million USD was leveraged through Government of India's PIPs to scale up Dakshata. So this is a very powerful slide that shows the journey, how when Dr. Sood shared the initial safe childbirth checklist, which started as a proof of concept and which now is going to 2,000 facilities across country. That's the powerful story that this slide says. Next one, please. I'll skip this one in the interest of time. Next one. What are the key take-home messages? And I have said this through this presentation, but I would repeat. One is, you don't improve quality if you just do trainings or just technical clinical updates or anything. You have to adopt a systems approach. And by a systems approach, what I mean is dealing with both competencies, commodities, accountability at all levels, including ensuring availability of data, availability and utilization of quality data. That is data for quality, that data that can measure quality, not only the access related data. And you need to have that data. Once you get these broad system level enablers in place, you will see change happening in quality of care at a reasonable scale. The second key, this is a big take home message. No rocket science here. Again, we all have learned through various projects that we have done in our life, elsewhere as well. The other one was, you just can't do trainings and back off, because most of the skills and competencies will fade if you don't follow up the trainings with on-site mentoring visits to help the provider translate what she learned or he or she learned in that training to practice in the labor room. And then ensuring key commodities are available, at all points, because you train the providers, and if the key equipments are not there, commodities are not there, the skills will go, they'll lose their skills because they are not able to practice. And finally, use of data, granular level quality data that the system can generate, not through any external source that the system can generate, is extremely important to ensure that there is sustainability, in the quality improvement process through the course of the journey. So I'll stop there. I must have taken more than my allotted time, but I'll hand it over to Sunita.
Thank you so much, sir. Now, I would request Dr. Sunita Dhameja to talk about brief overview of training package. Dr. Sunita Dhameja is a qualified obstetrician and gynecologist with masters in public health, having a vast experience in gynae ops and public health. She is an advisor for clinical services and trainings at Johns Hopkins affiliate in India, known as Jhpiego, and is a certified international training expert. Over to you, ma'am.
Thank you, Dr. Komal. Anusha, please share the screen. Anusha, please share the presentation. Thank you. So full screen. Thank you. So as Dr. Somesh said that there are four objectives of this Dakshata program, and there are four components, key components of Dakshata program: focused and customized training, strategy for transfer of learning, availability to ensure availability of resources in the labor room, and fourth one is improve monitoring and accountability of providers. So I will talk about the first two components, focused and customized training and strategy for transfer of learning. Next slide, please. So the first component of focused and customized training, some prerequisites for this successful training plan is first is identification of master trainers and the training sites, and identification of the sites with high delivery load, because these are selected and these are first to be saturated. Then assessment of the training load, that means how, and this is done through rapid assessment, initial baseline assessment, that staff are available in the labor room, posted in the labor room, and after assessing the training load, then micro planning for the training was done, and preparing for the batches of the for the training. And it has been kept in mind that all labor room staff, irrespective of the previous training status, should participate and should have this training. And so there are two types of training packages. One is 5 days training of trainer package, and second one is 3 days basic training package for the labor room, all labor room providers. And the foundation of this training, Dakshata training, is basically on the WHO Safe Childbirth Checklist. And all the 19 essential high impact practices are included in the training package. So this Dakshata training is a competency-based training approach. And in this competency-based training approach, all the domains of the competency, that is knowledge, skill, and change in attitude, were taken care, and based on knowledge, giving knowledge and building skills and change in attitude. Next slide, please. So training methodology, so all the domains were kept in mind. So for knowledge, interactive presentations were used, and audiovisual aids, checklists, job aids, and videos they were used. And for skill building, simulation stations were prepared with mannequins and case-based practices. And in the classroom, for hands-on practice, in the classroom, there were practice session, hands-on session on models, as well as in the training package, there is a slot for labor room visit also, so that providers, they can directly observe the practices and the setting in the labor room, along with how the providers are keeping records and reports in their labor room. So, all the labor room staff posted, that is doctors, staff nurses, LHVs, ANMs, who all providers who are posted in labor room, they were given this training. Next slide, please. And if you see the training agenda, this absolutely this is based, or foundation is on safe childbirth checklist. There are 4 pause points at the time of admission, just before and during delivery, just after delivery, and at the time of discharge. So all the 19 essential high impact practices at all these 4 pause points were covered in the training. Next, please. The second key component is strategy for transfer of learning. As Dr. Somesh has already said, that training alone is not sufficient. Mentoring is equally important, so that the providers, they can, so that the transfer of learning can take place and the providers can adhere to the practices. So in this mentoring or transfer of learning strategy, the engagement of the facility leadership is very important. For this, all the clinical and administrative leaders of the facilities, there was an orientation for them, and the government's initiative was taken that from the national government as well as from the state governments, there was order released for the non-rotation of labor room staff. That means the staff who is trained in this training should not rotate to other departments, so that they can provide quality services in the labor room. And the post-training follow-up, this is through the mentoring support, so that the provider can adhere to practices. Next. So in the mentorship program, part of this Dakshata program, the mentors, they provide the technical support, they provide the program support, as well as administrative support. For technical support, there are 2 types of mentors in different states. The states has their own strategy to appoint these mentors. In Rajasthan, it has been seen that dedicated mentors have been appointed and recruited. And in other states, in-service providers, maybe doctors and nurses, they are chosen as mentors. So they provide technical support, and for program support, states have RMNCH plus A consultants, and for administrative support, district level program managers and supervisors play a role. And regarding frequency of this mentoring and support visit, known as MSVs, the first visit should be conducted within 15 days of completion of training. And after this, the frequency is every 15 days for next 2 months, and then once in a month for next 6 months, and subsequently once every quarter for the next 3 to 4 quarters. And once the MSV visits have been, basic MSV visits have been completed, then need-based MSV can be continued based on the gaps identified. And these are structured mentoring and support visits. So every MSVs in mentoring and support visit, so every MSV has a set pattern that what the mentor will do in that visit. So these are 4 components of MSV visit. They will observe practices by the trained provider. They will do on-the-job hand-holding. If some gap is identified, they will review the facility records and give feedback to the nursing in charge after completion of the visit. And in this visit, they will check the provider's competency also through knowledge and skill competency, and as well as they conduct some mock drills also with the providers. Next slide, please. So now I will hand over to my colleague, Dr. Joshi. for the rest of the part and the impact of this program in Rajasthan.
Thank you so much. Now I would like to invite Dr. Chandrasekhar Joshi. He is an advisor, monitoring and evaluation, Jhpiego, India. Dr. Chandrasekhar Joshi is doctorate in statistics with having vast experience of developing, designing and implementing data-driven decision-making mechanism. Being a monitoring and evaluation professional, he worked with various health programs for Government of Rajasthan and Ministry of Health and Family Welfare, Government of India. Over to you, sir.
Yeah. Thank you, Komal. Thank you, ma'am. And good evening to all. So today I'm going to present our experience of, in Rajasthan, how we utilize our, during course of implementation of Dakshata, how we utilize our data for action through collaboration, adaptation and adaptive management and adaptive learning techniques. So Jhpiego is, the adaptive learning organization where, and we believe that, and we use our core principle during the course of implementation in Dakshata. So whatever we have learned from Safe Childbirth Checklist, so we as Dr. Sunita told, the Dakshata was, developed on framework of Dakshata on Safe Childbirth Checklist. So whatever we have learned from Safe Childbirth Checklist, we have implemented. Even we have utilized these five component of adaptive management and learnings, like engaging the frontline worker effectively, collecting data, real-time data or near real-time data, working through stakeholders, government for to establish a review mechanism and all these things, and creating an adaptive culture. So because our esteemed donors, Child Investment Fund Foundation, they strongly believe in giving a scalable and sustainable model to the government. So whatever we have tried and tested, we have given a sustainable solution in terms of reinforcing some innovation and digital technology innovation. So we did we created a adaptive culture in terms of developing MWMIS and mentor app, which I'll explain in my next slide. And the fifth component, which is equally and essentially important, that to revising our assumption, what we have learned during course of implementation. So what is adaptive management? Adaptive management is that this is the information, what is working and how, and what is not working and why, so that manager can take decision, and they can take they can do the mid-course correction during the implementation itself with the help of the data. So how we use this this technique in our Dakshata implementation, I'll explain in my next slides. Next, please. So first thing is engaging the frontline worker effectively. So we as Dr. Sunita told, it was collaborative. It was a two-way communication kind of thing. It was not only just training. We engage them. We encourage them to speak, to involve in our meetings and all these things. And we also trained. We have conducted more than 250 batches in entire state of Rajasthan. We have trained 92% of provider at high delivery load labor room facilities in entire state of Rajasthan. 90%, more than 90% of facilities have been saturated, where more than 80% of provider were trained in Dakshata module. And as Dr. Sunita, Dr. Somesh, Dr. Bulbul, everyone said, training, we learned that training is not work alone. So, so the intensive handholding is equally essentially important. So we have developed a structured mentoring package, and we delivered in our intervention facility. During training, we conducted pre and post test, knowledge and skill assessment, and we have observed significant improvement in their skills and knowledge. During Safe Childbirth Checklist, we also learned that 80% or more than 80% of the staff nurse, they are conducting delivery in public health institutions. So you can see this pie chart. Are the majority of our trained provider are staff nurse. Next, please. So how the second domain, the data utilization for action. So we have developed a MLE plan for Dakshata program. We developed a structured data collection tool for periodic audits, mentoring, and monthly reporting systems. We also introduced, as I told, for developing a creating an adaptive culture. We also introduced innovation like MWMIS, Maternity Wing Management Information System. We were keep tracking our progress of periodic assessment, adherence of practices, resource management through effective data analytics tools and devices. And we simultaneously we also ensure the data quality, as because it is equally important to collect to ensure the data quality. So we ensure data quality through validation checks, through various data triangulation techniques, through monitoring field visit, and all these things we have utilized for our improving our data quality. And with all these things, how we can utilize and disseminate our data for decision making. So we have developed a robust feedback mechanism with at every level, at facility level, at state level, at district level. So there are fact sheet, dashboards, everything. We have institutionalized, we have established a mechanism where government can review these data and they can take decision based on this data. Next. Yeah, so these are 26 essential items which we have identified during safe childbirth checklist. These are 26 items which should be made available 24/7 in the labor room for performing practices. So you can see when we started in mid 2015, the resources was not up to the mark, but when we phased out in later 19, so in the more than 90% facility, more than 95% resources were available. And in next slide, I'll explain how this could happen. This could happen with the help of data. Next, please. Yeah, so these are the driver of success, how we utilize our data for improving these resources. So in our MSV, in our periodic assessment, the resources was on high priority. We did bottleneck analysis where each and every level where is the issue of this unavailable resources at facility level, at state level, at store level, facility store level, or at the state level. So we identify each and every level where these bottlenecks and all these things happens, and based on this we have developed or institutionalized this resource availability metrics on every quarterly basis, where we disseminate with the state and with the district. And at the facility same time we pasted a sun board. You can see bottom of this in this slide, left right hand side. So we pasted this sun board, and our assessor used to maintain this after each and every periodic assessment and each and every audits. They write the scores, how many out of 26, how many items are available in that particular facility. So with all these efforts, now the resources have been improved. And the same time, what response we receive from system, from government, what they did at lower level facility, when for some small item like gloves and sterile pad, there were shortage in supply, so lot of local procurement also been done. And where if the system is not working after 2 or 3 simultaneous the visits, the things are not happening, then also show cause notices also issued to these facility in charge, why they are not maintaining the minimum saturation level of resources. Next, please. So this is snapshot of how we utilize our data. This is the monthly feedback system, state fact sheet we developed, district fact sheet we developed, which was being discussed at every district health level society meetings. At facility level, we institutionalize a mechanism of detailed action planning on based on, as Dr. Sunita told, we have identified 19 standard, and based on these 19 standard, what are the major gaps are there. So in terms of practices, in terms of labor room infrastructure, in terms of resources. So based on each and every gap, our program officer develop a detailed action planning mechanism at the facility, where the timeline was, the timeline was decided, and who will be the responsible to, addressing these gaps was also been part of this action planning. And similar, like these audit score also displayed along with the resources at the facility itself. And we also use composite index based facility ranking. So this is, based, composite index was based on resources, labor room environment. These are 26 resources, 7 labor room environment related standard, and 19 labor room practices related standards. So we have developed this composite index, and on every quarterly basis, we disseminate this score, which facility is on top, which facility is on bottom, what need to be, take corrective measures, what are the major gaps. So these all things were, ongoing for last 3 years when we were implementing this Dakshata.
Dr. Joshi, please move fast,
Yeah.
Because
next. So this is the third domain where we work with the government part, with stakeholder, where government, the periodic review, the video conferencing at district level, at state level happening, and when each and every meeting, when all the major gaps and all these things were discussed, and government also took affirmative action based on our feedback. Next, please. Based on this performance scorecard, the periodic reward and recognition was also happened based on, the government also, rewarded to the good performer based on the performance scorecard also. Next. At the same time, the corrective action also been done based on the data. Many show cause notice issues to, the facility in charge, whether they are not performing practices, whether they are not maintaining resources, etc. Next. Yeah, so the fourth domain is creating an adaptive culture through digital innovation. So once we phase out from, in Rajasthan, so how the show will go on. So the government, identify and hired a dedicated mentor, Dakshata mentor, for each and every state in Rajasthan. And we have developed this device, the Dakshata mentor, with the help of SIF and government of Rajasthan. We have developed this device where the mentor can, enter their visit data, their resources, and on what topic they have mentored. So they can, utilize this device for reporting and recording their routine monitoring system. So as of till now, more than 900 government users have been enrolled in this device, and more than 6,000 plus visits have been carried out through Dakshata Mentor app. At the same time, we have also developed maternity wing management information system. So it is a digitization of labor room. So it was rolled out in our intervention facility, but later government realized that there should be some real-time data entry mechanism needs to be in place. So right now, currently government of Rajasthan now institutionalizing the real-time data labor room intrapartum package in high delivery load facilities. Next, please. So the fifth domain is revising assumption. As 19 standard, we were keep tracking our 19 standard throughout, Dakshata implementation. So earlier, these 9, you can see after, 3 years, few standard is still not picked up. So we strongly believe that, it is happened because, so many new manpower comes, frequent transfer in, transfer out comes. So, so we realize that yes, training is important, mentoring is important, but the provider competency tracking is also important. So we have introduced this provider competency assessment module in our Dakshata mentor. So now government is using, and they can on periodic basis after 6 months or 3 months, they can review their new, if new provider comes into the system, they can assess their competency, and if they found they're non-competent, or so they organize your on-site training or refresher kind of training for the providers. Next, please. So because with the help of all these tools and techniques, it the convert into the positive outcome in terms of positive outcomes. We have established a complication data reporting mechanism in our Dakshata facilities, and we have seen that more than 8% reduction in PPH referral. We have seen more than 10% reduction in pre-eclampsia, eclampsia referral, and newborn asphyxia referral also been decreased by 3 to 4%. And it is ongoing process. Now this complication reporting mechanism is part of the government's real-time monitoring system, the real-time labor room monitoring system, which is name is the Prasav Watch. So this complication reporting format, which was introduced during Dakshata implementation and utilized throughout Dakshata implementation period, it is now part of government routine real-time monitoring system. Thank you.
Thank you so much, sir. Now I request Dr. Hemang Shah to speak about learnings from Safe Childbirth Checklist, pilot to policy. Dr. Hemang is a public health and public health nutrition and management professional who leads CIFF's Child Health and Development portfolio in India. He led different public health and nutrition programs while working with state government, UN agencies, international health NGO, and the private sector. His areas of expertise and interest include maternal and child health, nutrition, neglected tropical diseases, health system strengthening, and immunization. He is a trained medical doctor with specialization in public health and is currently based out of New Delhi. Over to you, sir.
Thank you so much, Dr. Komal. So I'll be quick considering the time we have. So one of the key sort of learnings from Dakshata has been that how do we translate the intent of policy into a workable program? And to that, what Dakshata has really done is that how do we contextualize the quality improvement process in public health facilities who are starting from different levels. So because when this Dakshata started way back in 2012, there was all the different facilities in Rajasthan were at different places, and in terms of their journey towards the quality improvement. And as Dr. Joshi has mentioned, there was a lot of focus from the very beginning in terms of what is the kind of data that is being generated through internal monitoring. But there was also an attempt to look at what is the kind of data that will be required through external independent evaluation to give the kind of additional weightage to the work that Jhpiego team has done so brilliantly. So from the very beginning in 2012, there was an external agency in form of Public Health Foundation of India, which looked at what is the reduction that is happening in early neonatal mortality through Dakshata program. And when we saw that the results, there was reduction, almost 11% reduction in early perinatal mortality due to this particular intervention. It was then scaled up in Rajasthan as well as in Andhra Pradesh, and there too, there was an effort that the approach that was there in Rajasthan was different as compared to Andhra Pradesh. So in Rajasthan, it was more hands-on, where there were program staff at district level, at regional level, and at state level. Whereas in Andhra Pradesh, since the base sort of indicators or baseline indicators were better as compared to Rajasthan, there the support was much more on a strategic level. Again, both for Andhra Pradesh and Rajasthan, while the internal monitoring of the program was happening, there was an external evaluation, but there we were not focusing on the end line, because that is something as a proof of concept was already proven in the original safe childbirth checklist intervention done in Rajasthan. So in the second phase, what we focused on was whether or not there is improvement in adherence of practices. So there is also a lesson there in terms of what is the kind of data collection, both through internal implementing agency as well as external evaluation, needs to be considered when program sort of matures from one phase to another phase. There were also certain midline assessments which were done, and during this midline assessment, as in earlier session we saw that there were many course corrections that were made. So for example, one of the findings that was there in midline assessment was there was a chronic shortage of providers in multiple facilities. So what is it that it can be done in terms of reshuffling existing providers, adding additional providers, because until unless there is enough staff, enough trained staff, whatever you do in terms of the idea was that if we do not provide enabling environment, then there is very little that we can expect in terms of improvement in quality. There were also some sticky practices which were identified. So if we look at 4 pause points, the providers were very keen to start improving on the practices before the birth and immediately during the delivery. But the postpartum period was the period where not much improvement was happening. So there was also sort of identification of which practices need to be focused over a period of time. There was also an inclusion of what is the kind of client feedback that needs to be there, because if we start collecting client feedback, it has a different kind of impact on the decision makers. So both the feedbacks are important. What is it that is required for providers to perform adequately, and also what is the kind of feedback that we need to generate from the clients. But it was also a journey of patience, because since 2012, it is an ongoing effort of quality improvement. So it also provides us kind of information that what are the kind of programs where incremental changes need to happen, because we do not want to change what is already working, vis-a-vis what are the kind of programs where transformational change needs to happen, because those are not actually working. And while this program was being implemented, there was always the focus on implementation science part of it, because simultaneously there was also another similar QI work based on safe childbirth checklist was going on in Uttar Pradesh by the name of Better Birth Trial. There the idea was more in terms of identifying the efficacy of safe childbirth checklist, whereas in the Dakshata program it was more in terms of the effectiveness, whether or not what we are proposing for improvement of quality of care, whether or not it functions in Indian scenario with all the challenges that we know are part and parcel of public health facilities. And lastly, the learning that we have had in Dakshata, we are also now trying to look at in different other programs, maybe antenatal care programs or other nutrition programs or even mass drug administration programs. So there are basic components of Dakshata in terms of training or capacity building or mentorship visits or identifying and ensuring adequacy and of the available items there, or the overall accountability. So there have been a lot of learnings in the overall journey, which we are trying to scale up, not just for improvement of perinatal health, but across different sort of programs in the health system. Thank you.
Thank you so much, Dr. Hemang, for sharing the insights with us and showing us the whole journey from policy to program. Now, going to the Q&A session, the first question which is posted, I'll just speak and then I'll request the speakers to answer the question. The first question is, how can we minimize antibiotic misuse given that we are likely to reach resistance soon? So what do the speakers advise on this?
So Anusha, maybe I'll answer. Hello, I'm Yashpal.
Yes,
so on the basis of our experience, we design a 5I framework where we divide all these practices into 5I. So one of the reasons for poor adherence to any practice is inheritance. So if provider is learning something at the nursing college or medical institute, there are very high chances that they'll continue that practice. So we believe that if we really want to minimize the antibiotic use, in long run, the idea is to work with medical college, work with nursing institute, and make sure that they are using appropriate medicine at the appropriate time. But in shorter term, definitely we can work through our mentoring and support visit just to make sure that provider has enough knowledge and they are prescribing antibiotic as and when required basis. But in our experience, district hospitals are most difficult place to work because senior OBGYN and other medical officers, they keep prescribing medical antibiotics. So yeah, a different kind of a strategy will be required to address this challenge.
Okay, thank you, Dr. Yashpal, for answering the question. Moving on to the next question. The next question is by an attendee, which says the master trainer should be given to only interested person, otherwise it's a waste of time.
Yes, and so we completely agree with this statement. So initially what we did, we identified SBA trainer and we appointed them as a master trainer. But later we realized that they are not adding any value. So then we identify the quality trainers, and then again they were not limited to SBA trainer. At most of the district, our trainers are coming from the ANMTC or GNMTC. So it's a very important point if we really want to make sure that whatever education we are training we are providing is of quality use.
Okay, thank you, Dr. Yashpal, for answering the questions. These were the only two questions we had. I would request you all, if you have any questions, you may type the questions in the Q&A section or in the chat as well.
Sorry to interrupt, Anusha. There is one question in the Q&A section. That is, why Dakshata program not implemented in low delivery load or average delivery load facilities?
That was a kind of a strategic decision we took. In Rajasthan, if you look at the delivery conducted in Rajasthan, there are 360 facilities which are catering to 80% of deliveries happening in the public health facilities. And if you want to cover all the facilities, the number may go up to 1600. So just to make sure that we are using our resources, scarce resources in terms of mentors or program officers, we decided to focus only on facilities which have more than 40 deliveries per month or 50 delivery per month. But yes, government is now trying to cover all the facilities which are conducting 20 or 30 deliveries per month also.
Thank you so much, sir. Now I would like to request the Professor Vikram Datta to share his comments.
So thank you so much. Before I share my observations on this very excellent presentation by the Jhpiego and the SIF teams, I would just like to invite Dr. Dinesh Baswal, former Joint Commissioner, Maternal Health, Government of India, who has been the driving force behind this initiative scale up across the country. And then subsequently, I would also like to invite Dr. Ram Cheher, who has been actively a part of this program since its implementation part in the state of Rajasthan. So Dr. Baswal, sir, your comments, your observations, and we are very pleased to have you here, sir.
So thank you, Vikram. Actually, I am just crashing into the meeting. So, but fine. Actually, it's gives me a lot of pleasure that I am part of this exercise. When we started Dakshata, we actually, I distinctly remember I traveled myself to Alwar and saw what is happening around, and we had a great discussion with Somesh that how to implement this. So we had actually, conceptualized the entire thing that, the safe birthing checklist needs to be, in the, actually it cannot be standalone. It has to be, basically implemented with the case sheet, so that we also knew that when we go into the field, there is hardly any data which is being captured, and we conduct so many deliveries, but the data capturing is quite poor. So actually, with this one intervention, I think multiple benefits have happened into the system. One, that data basically capturing has improved. Also, we have moved rightly from the manual data to digital data. Also that a maternity wing management information system, also ASMAN also happened. So I think this intervention, and it continued, I think, with the support of Jhpiego as well as with SIF. This has culminated into a very good intervention, and I think a lot of learning has happened. And I hope that more of these such type of interventions are there, so that we can learn that how we can because one of the thing which also we got good insight in this intervention was how many times do mentoring happen. So basically this was a question which was actually bothering my mind when we started this intervention. So basically, because training though we keep doing, but once we do training and mentoring, how many times do we mentor? So actually this entire MSB structure, mentoring, supervision, we actually with the Jhpiego, we could make out very clearly that very structured type of mentoring has happened. So I think this has been a rather a fabulous type of one of the I think finest training which happened, and a lot of insight has gone into it. I think with it is still continuing in various states. Also, we this has been adopted by some of states like Madhya Pradesh, where and Odisha also, where this has been now being funded through NHM, and it is still continuing. I think some evaluation needs to be done every year or so that we learn that what is happening around and keep learning from it. Thank you.
Thank you so much, sir, for those insights into the scale-up of the Dakshata program. And it is very important to hear, as you were instrumental in scaling this up across India with the Jhpiego team. And with this, I have a question before I come to Dr. Ram Cheher. And the question is from Dr. Anupa. Dr. Anupa wants to know, could you please throw some light on the comparison with Better Birth trial regarding the culture-related and behavior-related interventions, which were successful in which was successful in implementing this program. So this question is for the Jhpiego team.
Actually, I haven't gone through the Better Birth trial, but as I mentioned, that we have a framework because we developed 19 standards based on the Safe Childbirth checklist, which have certain verification criteria. 131, not certain. So 19 standards comprise of 131 verification criteria. On the basis of that, we finalize the score of facility. So there are some practices which are deeply rooted in providers' behavior. Again, I come to that point: inheritance. What I learn in medical colleges, it's hard to forget, and we keep practicing those practice. For example, what we saw that certain harmful practices like augmentation of labor and fundal pressure, that were very difficult to change, but somehow with continuous focus on mentoring and support visit handholding, we were able to change those practices. But certain practices like hand washing, we even developed a targeted program to address hand washing, but there are certain barriers related with hand washing, and most important is providers understanding that why hand washing is important. So as of now, a few practices that I can remember clearly is assessment of the pregnant woman at the time of admission. That is something that need to be taken care of, because sorry, not admission, at the time of discharge, because in postnatal ward we have so many mothers, and our discharging process is not very streamlined. The second issue is hand washing, where we need to focus, and the another one is infection prevention overall in the labor room. But definitely, sir, I'll get back to you with more information, and I'll share with you, and then you can share with
So just to add, just to add couple of points, that the way this Better Birth trial was designed, it was sort of done at PHCs and CHCs. So those were the kind of facilities where Better Birth trial was done, vis-a-vis Dakshata, where it were the facilities where CHC and district hospital where more births were happening. Also, the accountability piece was something which was not ingrained to that extent, because it was more of an RCT rather than a systems approach and implementation science work. And there too, there was improvement in adherence of practices, but there was no improvement in the the reduction in stillbirth rate or neonatal mortality. So there is also a possibility that all the work was, and there was also, like, the authors themselves had also identified that there was challenge in terms of continuity of care, because the implementation was happening at PSC and CSC, and there might be referral happening at higher facilities, because all the adherence was happening at lower level of facilities, but it was not expanded till the higher level. So the way it was implemented, the context of Better Birth trial and some of the components of Better Birth trial was different as compared to the way Dakshata was implemented.
Thank you so much, Dr. Hemang Shah, for those clarifications. I think for want of time, it has been an exciting session. I would just like to be giving the concluding remarks and going to Dr. Ram Cheher for Dr. Ram Cheher's conclusion and his observations on being a part of this. Dr. Ram Cheher, please.
Thank you so much, sir. Good evening, and it's great to see the team all convening together for discussions on Dakshata program. Without taking much time, just some quick points from my side. As Dr. Hemang just mentioned, that it had been a systems approach that was one of the strong features for the program, which built in both the competency development, creation of an environment of learning, as well as enabling for the teams to practice what they have learned, ensuring there is an accountability, a system of accountability, both proximal from beginning from the facilities to the district level, as well as from the state to the district and to the facilities, which created a line of communication. Of course, the team facilitated these communication channels, but overall, we also saw that there was a sense of ownership for the program from the state also. So I think these all contributed in terms of creating the program a success, and the results were spoken of not by the state or by the HMIS, but also by the sample registration system in terms of the reductions which have been reported. I think this gives us a recipe that if a particular health system wants to improve their capability, wants to implement the quality improvement programs, what all they need to take care of. It being that competency enhancement is just one part of the puzzle, but what all rest that goes into the program in making it a success has well been demonstrated by the Dakshata. And I wish the team great success in their future endeavors, especially some of the areas that I feel that others can learn from are in terms of tracking the monitoring and accountability part and how it goes into improving the performance of the facility. It had been a fantastic journey so far, and wishing everyone in the team all the best for their future endeavors as well.
Thank you so much, Dr. Ram, for summarizing the strengths of this program and also the key implementation and the translational values from this program. I would just like to add in the end that the learnings have been excellent, and the sharp contrast which this program had with Better Birth trial was that mere rolling out of the checklist in ill-prepared facilities where the system readiness is not there and the ownership is not there. the systemness is lacking will not lead to any improvement in the outcome indicators as was seen in the Better Birth trial. So that is the first takeaway. In the state of Rajasthan, we would like to congratulate the Jhpiego team, the SIF team, as well as the state of Rajasthan and Government of India for scaling it up and showing meaningfully how, with the involvement of all the stakeholders and an active mentoring, monitoring, training mechanism, and focusing on the quality assurance mechanisms, the quality improvement can be improved. So this is the second most important thing. Heavy investment in terms of continued investment from the state governments, the state NHMs, and the development partners is the essential prerequisite or a recipe for success. That is the third point. The fourth point, which is very, very important, is few of the people have asked how to sustain. And that is where NQOCN would like to bring in the inputs. And the inputs here are that we all know that the guidelines have been existing, the checklists have been existing, but how to have a contextual implementation of these guidelines and checklists through a participative team approach, which is leading to a culture of continuous quality improvement in the facilities, even after the supporting partners and the development partners have exited, as probably would be the case right now in these facilities. With the government taking the ownership of the program, it becomes very, very important that the teams are skilled into the practice of using the plan, do, study, act cycle and identifying their own problems, trying to problem solve without depending heavily on external resources and depending on external mentoring support. And punitive action and human behavioral factors are some of the very, very important things. Punitive actions in quality improvement probably have an effect which is only temporary and they may put off the morale of the team. So that is what our experience suggests, that rather than punitive action, we would suggest more that the hand holding, the community participation, the team building approach, and using the plan, do, study, act cycle methodology, which can be added on top of this beautiful program structure, can go a long way in sustaining the gains, and it can be then scaled up across the country as a part of the various national programs. So with this, I come to the end. Any concluding remarks from Bulbul Sood ma'am before we end this webinar? It has been an exciting journey, and thank you so much for bearing with us. I think we lost track of the time because the discussions were so lively and so insightful. So I just hand it over to Bulbul Sood ma'am for any concluding comments, and hope to see you over a subsequent session next month. So over to you, ma'am.
Yeah, thank you, thank you, Bulbul ma'am. If I can interject in between, so thank you for this wonderful session to the Jhpiego team. And since all of us are gathered here online, I would request all the panelists to kindly switch on their videos, and we'll keep taking the screenshots while Bulbul ma'am will give her concluding remarks. So over to you, Bulbul ma'am, and sorry for the interjection.
Thank you very much, and thank you very much, Professor Datta, for giving us this opportunity to share the work. And as you said, there are several learnings for all of us. I think you have concluded very beautifully, about the learnings. I would want to add one more thing, that we always underestimate the power of the providers. I feel strongly that most of the providers, when they go out to work, they want to do a good job and they want to provide quality care. Sometimes they are not able to do because they don't get enough support. And I think this program, because we use the systems approach, we didn't take punitive action. We made sure that, one, we were, not just giving education, but skilling people and giving them reason why you have to do a certain thing and why you don't do a certain thing. And I distinctly remember when we started this program in the beginning in Alwar, we were telling, don't give everyone, the normal practice of giving oxytocin, So what started happening, that people will come to the district hospital, and because they got, so much convinced that why they should not be giving oxytocin regularly to all the women who were coming in labor, that they started not giving. And the repercussion was that women will say, yahan to kuch hota nahi hai, hum ja rahe hain, because they started moving ki yahan par to kuch nahi karte hain, because they were in their mind, the clients were also expecting that they would be given an IV drip and something will start. The second thing which we learned that also is the power of teamwork. I found that, that we were able to change, and I strongly believe that, besides the supportive supervision, the mentoring, the monitoring and everything which was done, was that there were a lot of champions within the facility who saw that, they were able to save lives. They were able to do things. And I think that gave them confidence also, because I think somewhere the confidence was lacking. A lot of people had gone through, when we started, through that 21 days SBA training, but they said we didn't know anything. We hadn't learned anything. We hadn't done anything once, so a lot of drills and other things. And these frequent review meetings, which were not, again, it was to learn. I think that learning agenda has to be there for all of us, that, and it's a quality is a process. It's a continuous process. It's not at one time I've achieved and now I can sit. You have to continuously monitor, mentor and provide. And I think the biggest thing was that all the drug supply, the 26 items were there. So if I was a service provider, if I was a nurse, if things were there, I would be able to do. So I think sometimes, and I saw in the chat box someone saying, the paramedical don't want to work. I think, again, we have a lot of misconception that we work with, that, they don't want to work. I think you saw that most of the places, in fact, in the entire, not only Rajasthan, but in the country, 80–90% of the people who are providing the maternal care and also the birthing services are the nurses. And they have done an outstanding work in not just Rajasthan, but in other states. And I saw that there is a good partnership between doctors and nurses. And I think that's important. Interprofessional collaboration is very important if you want to provide quality care to the moms and babies in this country. And thank you very much. Thanks.
Ma'am, I think you have summed it beautifully. And the last line I would just reiterate to the participants: interprofessional partnerships and a good partnership and teamwork between the doctors, nurses, and the frontline health workers, and ownership and support from the system, which is receptive to the needs of the community. I think that is what is the takeaway, and you have beautifully demonstrated this. We would look forward to be learning more from your team as we progress into the years ahead. Look forward to an excellent collaboration. Thank you so much. And this is the main motto of the communities of practice, to get together the interprofessional partners so that we facilitate the learning processes in times of pandemic using this online platform. So good night, one and all. Thank you so much. It's been a pleasure hosting all of you. Looking forward to a equally exciting session next month. Thank you so much. Stay safe.
Thank you very much.
Thank you. Thank you so much.
Thank you. Stay safe, stay healthy, and just look after yourself and the family. Thank you very much.
Same to you.
Thank
Thank you
you
so much.
Thank you all.
Bye.